So, ladies, gentlemen, friends, and colleagues, welcome back to our Measuring Progress online forum on well-being, our by now nearly monthly appointment to discuss research, new ideas, and policy implications for well-being. Thank you for joining us today. My name is Francesco Sarracino, one of the organizers at Static Research, the research division of the Statistical Office of Luxembourg. And it is my pleasure to introduce to you our today's speaker, Giulia Slater, a PhD student from the University of Siena in Italy. Giulia's main fields of research are well-being and social capital economics. In particular, she's interested in the role of social capital in moderating negative life events on the well-being of individuals, such as the COVID-19 pandemic. Today, she'll present a work in progress titled The Effects of the COVID-19 Pandemic on Mental Well-being in UK, an analysis of the role of social capital, in which she uses nearly unique or finely grained, if you want, data from the UK Household Longitudinal Study to evaluate the impact of the COVID-19 crisis on mental health and assess the role of social capital in this relationship. Now, just before leaving the floor to Giulia, let me remind two housekeeping rules. For ease of posing questions and giving the possibility to everybody to ask a question, I kindly ask you to post your questions in the chat box. We will then pass them on to the speaker at the end of the presentation. The second is please keep your microphones muted. Without further ado, I leave the floor to Giulia, who has about half an hour for presenting, and then we will open the floor for discussion to everybody. Giulia, the floor is yours. And thank you very much for being with us today.
Thank you. Thank you, Francesca, actually, for allowing me to present here. It's a work in progress, so I would really much appreciate comments and questions if there are. I'll go ahead and share the
Please.
No, wrong button. So you should see my screen and with the title of the presentation.
Yes, and it's going full screen.
Okay, very good. So yes, as you were saying, Francesco, thank you. I will present today a paper on in which I analyze the effect of the COVID-19 pandemic on the mental well-being in the UK. And within this relationship, I analyze the role of social capital. So what I will do, I will just give a brief introduction as to why I'm doing the study, and I will go through a quick UK COVID-19 timeline. I will then give an intuition of what I intend by social capital, since there is no unique definition of social capital, it might not be intuitive. And then I'll present the data, the empirical model results, and then I will draw some conclusions. So what we know from the social capital literature is that the social dimension of individual lives is particularly important for health and happiness, and it is among the most important determinants of subjective well-being. And at the same time, both from economics literature, but also from psychiatric literature or psychology literature, we know that community perception, social ties, and social engagement are also tools that have allowed to build resilience in times of crisis, but also they lower the risk of mental disorder and increase adaptation and recovery. From the COVID-19 literature instead, as we all know probably by now, obviously, COVID has brought a massive negative health, economic, and health shock, especially to some subgroups of the population. And in some studies, or in this particular study that I have done with Francesco and Professor Bartolini, we found that higher social capital countries, in the sense that they had a higher trust, these countries explained a reduction in mobility, compliance to rules, but also allowed for better policies without necessarily coming at the expense for national health. This is to say that higher trusting countries managed to have a faster rate of declining of COVID cases without necessarily implementing such stringent policies. So another, yet again, evidence that social capital is important also in the COVID pandemic. But also from the US, there is a study that says that civic social capital showed higher compliance to isolating norms, to social distancing norms, probably because counties who have a higher civic capital, which I'll explain in a while, probably manage to internalize the cost of isolating because they think that they understand that they are doing this for a greater good, such as national health. Whereas counties that are more endowed with relational social capital showed lower compliance to the socially isolating rules, probably because of the higher cost of isolation. So my question is, what happened in terms of well-being during the pandemic? Around the same sense of the civic compared to relational social capital, we could think that although high social capital usually relates to better mental health, and this is well proven and well known in the literature, was this also true during the pandemic when the lockdown was implemented and when social capital was particularly affected by the lockdown and by the isolation norms? So is it possible that, I mean, I don't think it's that strange to think that probably people who have especially a higher personal relation component to social capital might have suffered the effects of isolation so much that lockdown has in the end offset the positive effect of social capital on mental health. So I believe there might be two kinds of pathways to analyze. So on the one side, a greater civicness and collaboration might allow for better mental health because of a better internalization of the costs of isolating, but also limitations to interaction with close people might worsen mental well-being. So my research questions are, on the one side, did lockdown eliminate the positive effect of social capital on mental health? But also, how did different components of social capital affect the relationship between the lockdown and mental distress? So just visually, what I'm trying to say is that I'm trying to understand what effect lockdown had on mental distress, because my dependent variable is mental illness. And I assume there's probably a positive effect, and that social capital has instead a negative effect of mental distress, so lowering mental illness. And what I'm trying to analyze is how social capital affects this relationship between the lockdown and mental illness. So again, since I'm studying the UK, it makes sense to give a little intuition as to what happened, although we might know what happened in the world. Since I'm doing a period study, I want to give a short timeline of what happened. So the governments of England, Scotland, Wales, and Northern Ireland have had some degree of autonomy in implementing and decreasing the stringency of the policies, although with different policies, they did implement these policies at similar times and within a similar range. So I studied the UK as a whole country. And what happened was that in April, when I have the first period of observations, the UK was in its first national lockdown, which was implemented on the 23rd of March, and which ended in England on May 3rd. But then this easing of the lockdown rolled out a few weeks later in Scotland and Wales. So by the end of May, the whole of the country was not in lockdown anymore, but they did have some isolation rules, so they could only meet with a few people and only outside. And so the easing of restrictions rolled out according to the cases until July. But then in August, cases started to rise again, and by between October and November, England went into its second national lockdown, which was lifted around the time of Christmas. But then, as we all know, in January, January marked the peak of the second wave of COVID infections. So the whole of UK went back into third national lockdown, which was still in place in March when I have my last period of observations. So this is just to say that, to remind what happened in UK around this period. So since my analysis works on what is the role of social capital within the relationship of COVID and mental illness, I think especially for those who don't have a clear don't really know the literature on social capital, or don't have a clear definition of social capital in their heads, I think the most common definition is the one that is given by the OECD. It was given in 2001, for which they say that social capital is basically the social networks, shared norms, and the norms of reciprocity that create values and understandings that usually facilitate cooperation among and within groups. So the UK has been doing quite a big job in putting resources into measuring both well-being and social capital. So they actually came up with their own definition of social capital in 2020, which is quite similar to the interpretation of the OECD, for which they measure so that they measure UK social capital, so social capital at the UK level, with a 25 indicator framework on topics such as social network support, trust and cooperative norms, personal relationships, and civic participation. So usually the proxies that are used for social capital in the literature are, for instance, if people have friends, if they can rely on friends, whether they don't feel lonely, or generalized trust in other people or in institutions. This is also a very common variable. But I was obviously in my research, I was restrained as to what the data gave me. So the data that I use for the analysis are data from the Understanding Society, which is a longitudinal and nationally representative study of the UK. What happens was that ISER usually conducts and has been doing so for a very long time. They conduct annual surveys on a random sample of the UK population. And when COVID hit last year in April 2020, they also implemented a special release on the effects of the pandemic on the UK on the UK population. So they went back and interviewed the same individuals who conducted at least one of the main interviews of the Understanding Society. So that in the end, I create a data set which is a balanced panel. So I'm following the same individuals throughout 9 periods. The first period of which is an observation for each individual, which was collected in the last wave, so wave 9 of the Understanding Society, collected in one point in time between 2017 and 2019 for each individual. And then these same people are interviewed again in April, May, June, July, and September and November of 2020, and then again in January and March of 2021. So my dependent variable is, again, since I'm interested in understanding the relationship between the lockdown and mental illness is my dependent variable, and it is measured in this case using the General Health Questionnaire, which has always been included in the Understanding Society data. And this variable is a self-reported instrument that has been used to evaluate mental health of respondents. And it also has been used to detect mental disturbances and psychiatric disorders in some cases. So individuals will respond to 12 questions on a 4-point scale. And the questions are on these general topics. So they ask about their concentration, whether they have been losing sleep, or if they have been playing a useful role, or if they have been capable of making decisions, or they feel under strain, or in general, if they have problems overcoming difficulties, enjoying activities, if they're able to face problems, if they feel unhappy or depressed, or their general happiness, and then about their confidence and worth feelings. So each of these questions is asked by each individual, and the answers are recoded so that they range on a 0 to 3 scale, and they are summed for each individual, so that in the end, each person will have a mental illness score, which ranges from 0 to 36, 36 being the person being the most distressed. So it's an increasing variable of mental distress. My independent variable is instead a social capital variable. So again, since there is no unique definition of social capital, and it's very much up to the researcher how to measure social capital and how to proxy it, without having necessarily any prior as to what would be the best variable for social capital, I collect some of the social capital variables that they are in the Understanding Society, and I perform a factor analysis on these variables. So out of the 8 or 9 variables I had selected, the factor analysis tells me that there are 4 components that are equally contributing to a latent concept of social capital. And these 4 components are very much similar to what the ONS definition for the UK social capital is. So this gives me also some sort of validation as to the 4 components of social capital that I'm studying. And I create dummy indicators for social capital. The dummies are created equal to 1 as an aggregation of the feeling of belonging to the neighborhood and the frequency of talking to neighbors for the personal relational component of social capital. And I turn to the friends module. So people are asked whether they can rely on friends and they can open up to friends. And they are aggregated and then transformed into a dummy for the social network support component. And the same thing happens for trust and cooperative norms. So I get the answers to the feelings of trust in neighborhood, in neighbors, and the feeling that my neighbors will help me in times of crisis. But I keep them separate in the civic engagement component because the Cronbach alpha statistics of the correlation between the two variables isn't as high as for the other components. So I keep associational activity information and volunteering information for each people separate. So in the end, I end up with five dummies for each of these components, but I also include lack of loneliness, which was excluded from the factor analysis when I did perform this investigation as to what were the components of social capital, because well, on the one side, the UK is putting a lot of effort into campaigning against loneliness, because loneliness has been a big problem in the UK in the recent years. And also it is in the definition of the ONS. So since I have the variable, I also include it as a proxy for social capital. So overall, in summation, I have 6 dummies, which I use at 6 different proxies for social capital, which gives me some sort of a value added because I am understanding how different social capital components work in this relationship, and I am not sticking to one prior that the researcher might have. This graph is trying to show you that so on the light gray bars are the averages of mental illness for people who have no social capital, whereas the dark gray bars are showing the average of mental illness for people who instead have high social capital. And the first thing I notice is that on average, high social capital people have lower mental distress, and this was true in all of the pandemic period. So each bar corresponds to one of the 9 pandemic periods I'm analyzing. But what I also notice is that in each COVID period, the increase in mental illness compared to the pre-pandemic was higher for high social capital people. So this jump was higher for people who have high social capital than for people who don't. So since this is only descriptive statistics, I try to understand whether this relation still holds when I do an empirical model. My empirical model is basically defined as a regression equation for which mental illness is my dependent variable. So the GHQ score is mental illness, and it's observed for each individual in each period. COVID is a time dummy, which is equal to 1 again in the periods I was showing you before. So I have a pre-pandemic period measured between 2017 and 2019, and then I have monthly observations until July 2020, and then bi-monthly observations between September, November 2020, and January and March 2021. Social capital is my main independent variable, and it's an individual-specific dummy for people who have high levels of social capital, and this is measured at pre-pandemic period. And I think I didn't say before, the dummy is equal to 1 for each person when his value for this variable is above the median respondent's value for the variable. So the threshold is above the median, let's say the median respondent. The main variable of interest again is so the interaction between the COVID dummy and the social capital dummy, which will give me a sense of how the different components of social capital affected the relationship between the lockdowns and mental illness. The regression also includes the standard set of social demographic controls for mental illness and happiness studies, such as age, gender, employment status, health conditions, or for instance, in this case, the risk of contracting COVID according to the NHS. And the model is quite simply estimated with a weighted panel ordinary square with the inclusion of random effects. So going to the results, I'm going to show the 6 equations, the 6 regression equation results split in 2. So on this on this slide, you can see the three components that are more in terms of relational social capital. So the social network support variable and the personal relation social capital component. So the social network support, just as a reminder, is a variable that was collected on the feeling of having friends that understand me and whether I can rely on friends. Whereas the neighborhood belonging on talk is a measure of my attitudes towards my neighborhood. So whereas I feel like I belong to the neighborhood and whether I talk regularly to my neighbors. And the lack of loneliness variables is quite straightforward. It's a dummy for people who never feel lonely at the baseline. So the first result that comes to the eye is that compared to the pre-pandemic period, so measured at the baseline, the COVID dummy shows for each of the regressions a positive and statistically significant effect, indicating that mental illness increased in each of the periods of the pandemic for people who have no social capital. So this is the average, and average mental illness increase in each period. What also this table is telling me is that at the baseline, so in between 2017 and 2019, having high social capital in each of these components, so for each of these proxies, lowers by far the effect of mental illness. So the coefficients are very high and statistically significant, indicating that on average, people who are endowed with high social capital, both in the social network support component and in the personal relation component, suffered a much lower, suffered much less, so they had a much lower mental illness. Then as I was saying earlier, my main variable of interest is the interaction between the COVID and the social capital variable, which in the regression for which I controlled for the friends variable, what this is telling me is that the difference between the two groups of people was in favor of people who have low social capital, because indeed having high social capital shows a positive effect on mental illness, indicating that in each period, having high social capital in the social network support deteriorated my mental illness compared to the baseline and compared to people who don't have high social capital. This was especially true in the first period, so in April when the lockdown was first implemented, and so the effect decreased a little bit throughout the period. What I instead found puzzling was that in June, when supposedly the lockdown started so there was an easing of the lockdown, the effect is positive and stronger than the other months. And I attribute this to the fact that possibly, similarly to what some psychological literature found during this period, there is some component of worrying about relatives and worrying about people close, because maybe I feel like I'm a vehicle of transmission of COVID, or I am unsure as to how I should behave. So maybe this effect also entails some part of worry. The same story goes for instead column 3, in which I use as a social capital proxy lack of loneliness. So people who are highly socially active, we could say. The effect is very much similar, but again, the difference between having high and low social capital disappears in June, because probably when I can go back to seeing people, then my mental illness goes back to perhaps a pre-pandemic period. So the effects between having high or low social capital disappears. There is no statistically different effect between having high and low attitudes towards my neighbors, because again, since this interaction is telling me about the difference in mental illness changes throughout the pandemic for the two groups of people, the fact that I don't find any statistical significance is probably due to the fact that the personal relation variable in this case is measured as an attitude towards my neighbors, and I don't believe necessarily that lockdown affected my attitudes. It would have only affected behavior. This is why I don't find any particular difference between the two groups of people who have a high feeling about their neighbors or they don't. What I do think is interesting to see about these results are the marginal effects. So the marginal effects are showing me that there is a consistent negative marginal effects indicating that anyway, throughout the whole pandemic period, high social capital people, despite having a higher jump compared to the pre-pandemic or no difference between the pre-pandemic, they still were better off compared to people who have no social capital. And this is indeed shown by the fact that in each of the marginal effect graphs, the effects are lower than zero and statistically significant. The other three components were instead on the civic engagement and trust and cooperative variables. So the civic engagement variable measured as high as being active in associational groups such as the partner groups. So for instance, religious groups or political groups or sports group, gives me some sort of moderation effect, at least in summer, meaning that, as I saw before, the effect on each of these variables is again positive and statistically significant, indicating that on average people suffered more throughout the pandemic. But indeed, high social capital levels measured as being active in associational groups allows people to suffer less at the baseline. In April, when lockdown was implemented, I'm not able to go to these perhaps meetings of the associational groups to which I'm usually part of. So I lack of the social interaction that I usually have. So the effect is to increase my mental illness. But this effect of increasing mental illness disappeared, and it actually goes back to negative in June and July, when indeed I can't go back to performing these activities to which I was used to before the pandemic. And then again, the effect increases compared to people who don't have high social capital when cases started to rise again and UK goes into national lockdown in January once again. I don't find any statistically significant difference between the two groups of having high and low social capital, measured instead as the feeling of neighborhood trust and help, because again, these are measured as attitudes, and for the same reason as before, I don't think the lockdown had any change on my attitude towards my neighbors. So once again, it makes sense that I don't find any difference between the two groups. What I do find in this case, again, is that instead the marginal effects are negative, indicating once again that high social capital in some sense prevents a deterioration of mental illness, and so on average is associated, so it correlates to a negative mental illness, so a lower mental illness. I understand the results might be a little bit confusing because they are very specific to each of the variables of social capital that I measured, but if I have to summarize them in a few phrases, I would say that what I found is that mental illness increased on average for both high and low social capital individuals throughout the pandemic, but this effect was particularly high for people who have high values of especially the relational component of social capital. So for people who usually have highly relational lives, going into isolation made them suffer more than people who don't have relational social capital. But overall, social capital is good for decreasing mental distress, even throughout the pandemic period, despite the difference in the two groups changing according to what social capital variable I'm looking at. So lack of interaction makes people suffer, but having a higher civic or collaborative attitudes, kinds of social capital, alleviated the effects, especially in summer when I could go back to, in the case of the group activities, go back to my physical activities, or it made no difference. And I guess this was attributable to the fact that collaborative attitudes are measured as an attitude towards my neighbors and not so much in the generalized trust as would probably be preferable. I find that results are robust to a variousness of robustness checks, which for the sake of brevity, I'm not going to show today. So I'll just go to the conclusions and say that although lockdown affected people who depend on their personal relations more than people who don't, social capital still allows for lower mental illness on average, meaning that policies to promote and protect social capital will ultimately benefit people's health. so that the study and the implementation of interventions to foster inclusion or connection and collaborations which go towards implementing social capital will ultimately also better the mental illness of people. And in the same way, a lot of study and a lot of interventions are going towards the mental illness prevention and increasing well-being. I believe that social capital being a determinant of well-being, it's important to study the interventions towards social capital as well. I also believe that exploring the effects of social capital on mental health will help address clinical and epidemiological challenges, such as ensuring national safety, which was the case for the COVID pandemic, without necessarily coming at the expense of individual well-being. So, for instance, I'm thinking when the lockdown was eased, and it was the first time, so nobody had a very clear path of how they were supposed to behave. Perhaps clear rules and guidance on behaviors and distancing norms might help people in finding the right way of how to going back to socialize in a safe way. But also, if it is true that isolation was detrimental for mental illness, then trying to engage people in virtual engagement also might have helped. Although I didn't myself check for this, but I think it could be worth doing probably in the future. So I think I close here. I think I was shorter than time, but thank you. And if you do have some questions or comments, I would greatly appreciate them. Thank you.
Awesome, Giulia. Great. Thanks a lot also for being spot on with time, with exactly 29 minutes. So you made my chairing job fairly easy. Thank you for this. We have already a first question from Sama Abdallah, who asks, actually it's a clarification question. Did you say that the social capital moderator used in the regressions was based just on the baseline social capital, or did you use the social capital values from each wave, for each wave?
Okay, no, I only use variables that were measured at pre-pandemic period because, well, on the first page, they didn't really ask a lot of questions on social capital in the COVID pandemic. They only asked a few and in very sparse points in time. So I wasn't able to include social capital in each of the COVID periods in any case. And I don't think it's too much of a problem because although lockdown might have affected some components of social capital, I don't think there is so much reason to believe that social capital would have changed that much throughout the pandemic. So maybe my behavior towards social capital would have, but not social capital per se. So to answer the question, no, it was measured at pre-pandemic.
Thank you. Sama, did she answer your question? Are you satisfied? In the meanwhile, I will pass on the next question from Christophe Ferreira, who says, when talking about the measures of social capital, you said that one point is talking to neighbors, and another one is trusting and helping neighbors. Aren't they influencing each other, since people often talk more to people they trust than to people they dislike or distrust?
Yes, you're right. You're right. I also had the same suspicion, so I tried and I plotted the correlation between the two variables, and the effects surprisingly weren't that high. So I didn't actually include all of the social capital variables within the regression equation of the other social capital. But again, the correlations weren't that high, even though one would think that they were. I'm also guessing that these two variables were asked in different periods in time in the understanding society data. So two of the variables were asked a few years before than the others. So it's likely that they didn't really correlate. I hope that answers the question.
There is a question, actually, questions are popping up in the chat box. There is one by Chiara Peroni. How can you claim this is the effect of lockdown? Can you disentangle the effect of lockdown from the effect of the pandemic with your data?
Okay, no, this is an interesting question. Actually, I used lockdown as a very general term of COVID crisis, let's say. So I guess one way in which I could disentangle the effect of lockdown compared to just COVID crisis would probably be maybe studying the different timings in which the lockdown was eased. I think in Wales they eased the lockdown later compared to England, for instance. So maybe I could probably have a different comparison between the governments in the UK, but I didn't really do this in my analysis. But I guess that would be a way of checking, I guess, if I understood your question correctly.
While waiting to see if Chiara, okay, so while waiting to see,
thanks.
Okay, good. Then Giovanni Burro would like to ask a question.
Yeah, I'll go for the traditional way. So thanks a lot for the talk. This is quite nice. So first, I have a comment after Chiara. Probably one way to identify effect of lockdown versus effect of just pandemic could be checking how much people were affected by lockdown. I don't know if you have questions like, were you able to work remotely? Have you got children at home? Like all this kind of stuff. Like for some people, lockdown changed life a lot. So pandemic was the same for everyone, let's say, but lockdown hit differently, different type of people. I don't know the questions which were asked, but you could check for this type of stuff.
Sure.
I don't know, but my question was another one. This was after Chiara. My question was, on the very first result, I don't remember which was the measure of social capital, but you had this big coefficient on the June dummy, and you're saying it could be related to people being more worried of infecting their inner circle or this kind of stuff. Again, I don't know about the questions, but I guess that you have some questions which are, how worried are you about the pandemic, or some estimate of like how likely do you think you're going to be infected, this kind of stuff. So you could actually check this explanation. So you could check if these people are actually also more worried about the pandemic, and more worried about the pandemic maybe in June, because once the lockdown is lifted, they actually get more worried because they felt protected by lockdown, but after lockdown they're now like, oh, like they're more worried because, yeah.
Sure, thank you. To be fair, I think it would probably be easier to find the variables on the were you affected by lockdown, because I have seen the variables a few times and they didn't ask a variable, so they didn't ask a question about the worry for the pandemic until later in January. So my second to last observation, so I had, my guess was just out of what I have read in the literature. It was I couldn't check for that specific hypothesis, let's say, but I think I could go back and check instead if the lockdown had different effects on different people for employment or for having children at home, or how they managed to cope with the living inside the houses for such a long period, more than the worry, because unfortunately they didn't ask. Yes, but thank you. Actually, if I do find a way of checking for that, I will definitely consider it. Thank you.
Great. There is one more question from Chiara, and then before going to Sama, who now has a proper question. So Chiara asks, what's your concept of mental health? Is the self-reported measure you used capable to capture serious mental illnesses as compared with mental distress, which may be temporary following lockdown? There is evidence from the UK concerning how the pandemic has affected differently these groups. I don't know which groups, but I think the first part of the question is pretty much clear.
Yes, so the General Health Questionnaire has been used in psychiatric literature, in psychological literature, and whoever does health economics to find the general level of distress. So
perhaps you can show, sorry if I interrupt you, perhaps you can show again the slide dedicated to the...
Yes, I'm not sure if you're seeing the slides or...
Yeah, you're still sharing.
Okay, so I have these are the questions of...
No, actually I don't see it. It's just a white screen.
Okay. Now? I changed the layout.
You're back.
Okay. So yeah, the variables that they ask are the ones I listed earlier, but I used an additive measure, so that which was already given in the Understanding Society, for which they add these 12 questions, and then they just say that it's a continuous variable, so you can range between 0 and 36. They also, however, provide the variable which is derived from the same questions, which is the General Health, the GHQ caseness score, for which then the answers to these 12 questions are recoded so that they range from 0 to 1, so that the continuous variable would range between 0 and 12 being the most distressed. And psychiatrists usually use this as a screening method to see whether people are likely to have a mental illness, so treatable under psychiatric conditions, meaning with treatment or whatsoever, when they have a score which is higher than 4 out of 12. But this, I haven't seen it much in the economics literature. I've seen it in the psychiatric literature a little bit more. I didn't use it myself, but I guess I could check and maybe see whether people go, so to say, they go over the threshold of probably being screenable as in mental illness condition. I think this was the question, right? Did I answer sufficiently?
Yeah, thanks. I was, if I can intervene, Francesco, I was wondering, perhaps you could try to use different items from this question to see whether it could be a robustness check also. Yeah.
Sure, I did do it with the depressed variable, which was the most similar to mental illness or having difficulty overcoming this pandemic period. So I did use it on the depressed variable itself, and the results a little bit lower in magnitude, but they overall were pretty much the same. But there were less people who were answering to the unhappy or depressed variable in such a way that gave me a bigger enough variance in the sample. But I will put it probably in the paper when I write it, yes, as a robustness check. Thank you.
Thank you.
Thank you. Thank you. Someone would like to step in.
Thank you very much. And thank you, Giulia, for a very interesting presentation. I would love to do some of the kind of analysis you're doing. But there is kind of, I guess, one sort of danger here, or sort of problem in terms of your interpretation. It could just be that people who have higher social capital have lower mental illness, okay? And so that when there's some kind of big shock, there's more room for them to travel into that variable. It's not a ceiling effect, but it's because there's still a lot of room to travel there. But Francesco, when you're typing, it's
sorry,
it's very loud.
Yeah. Okay, so it could just be sort of like a ceiling effect, basically for people who have low social capital earlier. There's more room for them to travel in terms of increasing mental distress. than for the others. I think it's quite hard to test for that, but I'm just wondering, is it you could theoretically look at two other groups that have different levels of mental distress for which you don't have any a priori reason or any theoretical explanation for why those groups might differentially have been affected by the pandemic. I can't think off the top of my head of anything, but I mean, because obviously with unemployed people, for example, suffered less from the pandemic, so their well-being didn't go down as much as people who are unemployed. But there may well be some other pair of groups that you could compare where you could say there's no a priori reason to expect that they will be differentially affected, and hopefully they won't be differentially affected.
Yeah, that's interesting actually. I'm myself trying to think with the questions I have how I could check for this, but I'm not sure. Maybe people who went into furlough, for instance, but I would expect a decreasing in mental illness for them because clearly they lost their job. So I'm to be fair, I'm not completely sure I understood your question correctly. So you would, as a check, I would have to see whether two different groups of people who were otherwise from the pandemic would have had no difference in mental illness. Is basically, that what you're saying?
Yeah, the counter hypothesis is basically if you take two groups that had different levels of mental illness before the pandemic, the one that had better health would suffer more, just because that's
right.
The way. Just, I mean, it's almost a regression to the mean effect, you know, like just basically if you've got more room to travel, then you'll travel more.
Oh, yeah. Sorry, I was
just think of a couple of a pair of groups that might be relevant, but yeah, it's a tricky one.
I would have to think about it, actually. Yes, thank you very much. Thank you.
Great. So I turned my mic back on again. Sorry for yeah. Sorry for that. There is one more question by Christophe and actually also one from Chiara. I'll go by order. Christophe asks if there is a specific reason why you focused the analysis on UK. Is the data available easier over there? Do you get more diverse results than in other EU countries, or is there any other reason? And the question by Chiara, well, she's apparently more concerned about endogeneity. She says that social capital is likely endogenous to mental health. People with mental health issues usually suffer social isolation, even in the UK, which has anyway much less stigma attached to mental illness. So can you control for this?
Okay, yes. So to answer Christophe, I use UK data because, quite frankly, it was very easy to get to their data, and because they did release their the Understanding Society COVID special release of data, let's say, very easily and very accessible to everyone. Whereas, for instance, it wasn't as easy to find the German data. Italy has no such information at the moment, or not so such granulated at the individual level. So it was a matter of accessibility to the data on the one side, but also the UK, together with a few other countries, is doing a lot of, they're putting a lot of resources into measuring well-being and measuring social capital and actively budgeting their public money towards ameliorating lives of people. So I thought this would go in the literature for the UK, hopefully it would give some more insight on the UK. So that was also, I mean, it's one of the few countries which is very out there using mental illness and putting it into the budgeting. So this could also go towards that direction. So that was the reason why. I can't remember if you asked me anything else. To be fair, when I started with this, I didn't go back to check whether European countries have this kind of information as well. Not yet. I might do it, but I haven't done it yet. So. Whereas for the endogeneity of mental health, this is very true. It's one problem that, so this analysis that I showed today is very new. I've been doing it for the past few weeks, but I did the same thing with another indicator of social capital, and to check for the endogeneity, I used an econometric technique for the so it was the Lubel method. So for the generated instrument method for instrumenting social capital when I don't have any available instruments for social capital, because they will likely all be suffering from this indigeneity problem. So my next step will be to probably do the same analysis with the Lubel method and see whether the results hold. I think this would, on the top of my head, would be the only way that I could check for indigeneity as of now. But I can't remember the second part of the question. So I remember the indigeneity part, but I couldn't really remember the rest.
Well, let me step in exactly on that last note, as we have a few minutes left. Sure. I wonder if you have in your data set personality traits, because they could be used as predictors of social capital, and therefore help you either controlling for those, because they could also predict, they could also correlate with GHQ. Perhaps, I'm not an expert. Or you could use them as predictors of social capital in a two-stage least square.
So yes. So I did plot a correlation table for the social capital variables with these personality traits. I could show them. I think I still have them in the. I think they are here. It might be tiny. One problem with doing this is that the last time these questions about the personality traits were asked in the Understanding Society was at least 4 to 5, I think 5 years before the baseline period. So they are quite old. So I would be losing part of the sample because they were interviewed later in time. So I could do it, but I would be at the expense of losing some of the observations that I had. But anyway, the correlation table is telling me that indeed extraversion is the one that has the highest correlation with some of the social capital variables. But I didn't do a regression of social capital on personality traits, so I wouldn't know. They correlate, but I would have to check whether they are predictors for social capital. But if they are, then I could definitely use them as in a two-stage square. Actually, yeah, it would make sense. Thank you. I guess, yeah.
And there is one additional comment by Sama. Sama, would you like to give it a voice?
It could just be copied and pasted for later, but I did think of another variable you could use, which is self-reported health. So people with good self-reported health will have higher well-being, sort of lower mental distress than people with bad self-reported health. And I can't think of any theoretical reason to assume that people who had good self-reported health before the pandemic would suffer more than people who had bad self-reported health. So you could do a comparison, and hopefully the interaction effect there will be smaller, at least, if not non-existent. So.
That sounds like a nice idea.
Yes, thank you. I'll look for the chat, and if you did write it in the chat, I'll copy paste it, so I'll remember all of these comments. Yeah, thank you. Thank you very much.
Okay, awesome. We are approaching the end of our 1 hour slot. Do you have any more questions? Or if you have still questions and comments, is there an email address where listeners could reach you?
Sure. Oh, I think my screen is not working with me. Yes, it's Giulia Slater at gmail.com. It's very simple. But please, comments, questions, anything. I would greatly appreciate them, because some things I didn't think about myself. So that's useful. Very useful. Thank you.
So in that case, let me wrap the seminar up. I wish to thank Giulia for being with us today. I wish you best of luck with the continuing of your research. And I wish to thank you all who showed up today and who attended and contributed to this lively discussion. I wish you all a nice continuation of the day wherever you are sitting. Hope to see you soon. and most of all, stay safe. Bye-bye. Thank you.
Thank you very much. Thank you. Bye.